I'm very excited to introduce this panel at the moment. This is, I just said to Joanne, the poster child for Empower. The University of Maryland at College Park and the University of Maryland at Baltimore, while 30.3 miles apart by my Google map, are actually joined at the hip in many ways, and if we would just get someone to build a light rail up 95, or a hovercraft over 95, or a drone up and down 95, wouldn't we all love that? So it would not take us forever to get up and down the road. But of course we have Skype and all other kinds of ways to talk with each other. But this panel is particularly important. The state of Maryland is on that list of the higher quartile for cancer. And so cancer prevention is very important. And our panel today, which would speak to cancer prevention and population science and the establishment of a Maryland Cancer Survivorship Cohort, I'd like to introduce our colleagues. Cheryl Holt, who is directly to my left here, is in the Department of Behavioral and Community Health at the University of Maryland, College Park. And I would like to just add, and this graduate of the same obscure upstate New York university, State University of New York, Brockport, which Dr. Gold and I both also are alums of. Yes, no, just shameless plug. Yeah, it's an interesting connection. Joanne Dorgan, who is a professor in epidemiology in Dr. Magaziner's department, and Rhonda Boozer-Yeary. Yeary. Yeah, it is just as it says, right? Who is a community health educator and works with the UMD Greenebaum Center. And our interloper at the end of the table is one of my favorite faculty in the school. I can't say that to all of them because they're all my favorite faculty. But Cher Dalal, who's in the Department of, yes, and Tiffany is in the back. Yeah, I thought I was your favorite, Jane. Cher Dalal, who is in the Department of Epidemiology and Biostatistics in the School of Public Health. Ladies, take it over. Thank you. Again, if at the end of the day, if this is your last session, put your tags, we recycle, in the badge back there. Lunch after this, 2 sessions, poster session or the networking tables. Thank you.
Thank you.
Mm-hmm.
Thank you. Great. Fantastic. Great. Thank you, Dr. Clark, for that delightful introduction. Thank you. All right. So we're going to talk about population science and the population science program at the University of Maryland Greenebaum Cancer Center. And so population science is one of 5 scientific programs at the Cancer Center. And the other 4 programs I would like to mention are the experimental therapeutics program, the hormone responsive cancers program, the molecular and structural biology, and the tumor immunology and immunotherapy programs. And we recently had our site visit at the Cancer Center. Went very well, and the UMGCC is one of the NCI designated cancer centers. And so it's really important to us, and we just had a really great site visit, and so I just want to kind of set the context. I always do that. Set the context for the population science program. And so just give you a little bit of history. The program we have a program timeline. It's based on a set of research that's been going on for quite some time on both campuses. And so I came in 2008. Bill Blattner became the Population Science Associate Director in 2009. Our current Associate Director, Clement Edemomo, also came in 2009, and so we have the UMCEA, or Cancer Epidemiology Alliance, that was formed in 2012, and that was kind of the cornerstone of the formal origin of the population science program. And then Dr. Dorgan came to us in 2013, and she is at the Baltimore campus, and then we became co-leaders in around 2014, co-leaders of the the ordained population science program, and that is when the external scientific advisory board of the Cancer Center indicated that it was time for the Cancer Center to formally designate a population science program in their pursuit of NCI comprehensive status. And so that was very important to us as a cancer center, and also really formally designating that program. And so Joanne and I have really worked to put together this program and the research in it, which I'll tell you about briefly. And then so our comprehensive cancer center application went in 2015 and was reviewed quite favorably. And so this is a bi-campus, importantly, as Jane had indicated, this is a very strong bi-campus collaboration. And we do this through several mechanisms that we span this divide. We have joint seed pilot grants, which are planting the seeds for those larger collaborations. We have joint faculty recruitments that are going on, cross-campus mentoring, which has been very effective. The cancer epidemiology course is offered to students on both campuses. The Cancer Center generously paid for a very sophisticated Polycom conferencing system, which allows us to really see each other and feel each other's presence. And we use that also for the seminar series in the population science program, and that's also available to others, folks that can use that for collaborating and video conferencing, which really helps out. We have a monthly seminar series, an annual retreat, and of course Public Health Research Day. And thanks everybody who came down from Baltimore. We really appreciate that presence. And so this is an example of how we use the Polycom system in our seminar series. So our membership, we've got about 40 members. That's kind of a moving target. We're always a little bit changing, but we have 78% of our members have peer-reviewed funding and cancer-relevant peer-reviewed funding. We're split relatively equally in membership across the two campuses, which is very nice, a very good strength of cancer-relevant funding and involvement across the two campuses. And we've got a very good representation of NCI funding as well. And so our program goal is to identify determinants of cancer etiology, cancer-related behaviors, and survivorship, and translate basic discoveries into behavioral cancer prevention and control interventions. So we have a very good representation of the epidemiological research and the behavioral science research, which form 4 themes that I'll tell you about here in our research program. And so the theme 1 is the epidemiology theme of infection, particularly of infection and hormone-related cancers. And this aims to identify the molecular, genetic, and lifestyle determinants of infection and hormone-related cancers both in the US and globally. And as an example, I'm just going to show a very brief scientific example of each of these themes. And this is the HPV research that is going on both in Baltimore City and in Nigeria, headed by Clement Adebamowo. Won't go into them in a lot of detail due to time. I want to make sure that we have time for the other speaker. So theme 2 is our tobacco and nicotine theme. This is a very big area of critical mass in our population science program, where we aim to characterize nicotine and tobacco products, identify biopsychosocial influences on tobacco use, and develop and evaluate novel prevention and cessation interventions with a focus on vulnerable populations. A very strong disparities theme running all through the population science program. And so I'll tell you about some of the centers in the population science program. One of them is the Tobacco Center of Regulatory Science, headed by Dr. Pam Clark, and that is embedded into this theme, a very strong theme in the Cancer Center as well. And one of the examples of the science going on is in the T course, where Pam is looking at the particulate matter generated by e-cigarettes and how that is taken into the lungs, and also the toxicity. These are the 3 projects in the T course center. One is looking at the microbiome. We have quite a bit of microbiome research going on in the population science program. Here is another theme 2, example of a behavioral activation research program going on in the psychology department by Laura McPherson, and she's had a good amount of success in cessation research through a program that she calls behavioral activation. Theme 3 is equity in prevention and early detection. This is our behavioral interventions, largely around cancer screening, prevention and screening. And this is some of the community engaged work that is going on to develop, evaluate interventions in particularly in medically underserved populations. An example of this is the work that Xiaoli Nan in the communication department is doing around HPV vaccination. And this is a message framing intervention where she observes some differences around the framing approach versus gain versus loss framing and the efficacy in African American parents in gain and loss framing around HPV vaccination. And then finally, theme 4 is our cancer survivorship theme. We have a very strong pain research program led by Susan Dorsey, and I'll tell you about that in a minute. This is reflected in the survivorship theme, where we identify mechanisms of cancer treatment-related pain and characterize individual treatment and community-level influences on racial disparities in cancer outcomes. This is some of Dorsey's work, very fascinating work on the genetic basis for experience of cancer pain and pain that may be going on when a person is being treated for cancer with chemotherapy. And so these are our 4 centers. We have 2 pain centers. We have the T-Core Center, tobacco, that I mentioned, and also the microbiome center that is going on in Nigeria. Very, very strong representation in the catchment area. Our catchment area is shown, the cancer center, as that big red swath right down the middle of Maryland. A lot of research going on in the catchment area in Baltimore City, in Prince George's County, as well as all of that area in red. So we're very strong in disparities research and research that really is impacting folk in Maryland and in the catchment area, as illustrated by these examples. And then in training, of course, is one of the missions of the Cancer Center. And we've got training, importantly, from all the way from very young folks all the way through postdoctoral training. And so we have, again, I mentioned the Cancer Epi course. The T course now has a very robust cadre of postdocs. I hope some of them aren't going to be here today. And the NIH development training grants, we have several training grants, as well as a number of faculty with K awards, and then a lot of formal and informal mentoring that is going on in the population science program. Certainly we are looking toward the future with increasing our community engagement research, particularly in Baltimore City, and smoking prevention cessation programs. McPherson is looking to expand her behavioral activation program, and additionally, we're looking to really formalize those mechanisms with the research going on in Nigeria and relating that to the applicability to Baltimore City, especially with the large immigrant population that we do have. Joanne will tell you about the data and biosample repository and the survivorship cohort, and she's going to talk about that, which is relevant to the last 2 bullets on this slide. So I will wrap up with that, and I want to introduce Ms. Rhonda Boozer-Yeary, who's going to talk about some outreach work that we are doing in Baltimore City.
Thank you so much, Cheryl. I am Rhonda Boozer-Yeary, community health educator for the University of Maryland, Marlene and Stewart Greenebaum Cancer Center. And I feel like I am the regular person here on the panel amongst such wonderful researchers doing great work. But I'm grateful to be able to collaborate with the great minds in trying to reach the community. Not that you care anything about me, but I am a graduate of the University of Maryland at College Park, 1991, woo-woo. And although campus looks to be a bit different, I knew how to find my way to the student union. So grateful to be here. I have been on the National Outreach Network Community Health Educator Grant, one of Dr. Holt's grants, for a whole 2 months. And I'm coming from the Baltimore City Cancer Program, which is an outreach arm of the Cancer Center. And that program provided free services to Baltimore City residents who did not have health insurance for breast, cervical, and colorectal cancer. Not only do they provide screening, but they also provide treatment as well, free of charge to people who are uninsured or underinsured. So the move into this position is kind of what I've been doing with some expansion. So I'm not used to this. I'm also a former elementary school teacher, so we weren't quite this fancy in the city, but here we go. As a community health educator with the National Outreach Network, we aim to enhance the National Cancer Institute's health disparities research efforts through local and regional, culturally tailored education and outreach in underserved communities, which is the catchment area of the University of Maryland Hospital. Also aim to enhance NCI's ability to disseminate culturally appropriate evidence-based cancer information to underserved communities and to adapt and test culturally tailored education outreach activities that address local and regional health disparity issues. And I'll keep going. If I start talking, I'm also a preacher. I do a whole lot. I'm a preacher too, so but I'm gonna keep going. So some of what we do in trying to educate the community and trying to get them to take good care of themselves are different outreach activities. And some of the things that we're looking to do is to implement the Project HEAL in Baltimore African American churches. That is the Health Through Early Awareness and Learning, which is a successful initiative that Dr. Holt has initiated in PG County, trying to do that in Baltimore City. Guess what? I have an in because I'm a preacher and I serve a church that sits right in Baltimore City. That's the first stop that we're going to make with that initiation. Douglas Memorial Community Church, where my husband pastors, shameless plug. Also, we'll be conducting and providing support for local health fairs, providing training and support to the Cancer Center researchers and community engaged research, working with existing community partners, other community health educators, as well as academic partners. We'll be collaborating particularly with UMGC initiatives such as CURE, which is continuing the umbrella of research experiences, and the Baltimore City Cancer Program. And just to tell you a little bit about that collaboration and a little bit about UMB CURE. CURE is a scholars program. I don't know if you all are familiar with it, but it's a groundbreaking science pipeline program in which middle school students, as well as some high school students, are exposed to healthcare-focused paths through school programs, along with weekend and summer components. Currently, they have approximately 30 students in the program from 3 middle schools right around the university, and they'll be looking to bring in 25 students now. They're in the recruitment phase now, so in September, they'll be bringing in another 25 students. And they provide a holistic approach to academic success by addressing basic family needs as well. So you have about 30 students. Currently, they have mentors 5 to 1, which is a lot, 5 mentors to 1 student, trying to help the students just make it and then expose them to careers that they may not be exposed to on a day-to-day basis. They take them to labs. They have access to folks like Dr. Holt to be a mentor. Just trying to exposure. We know that some folks just don't do things because they've never been exposed to it. So this is a wonderful opportunity for those who may not normally get exposed to this to do something different and possibly consider a career in that. What we do as a partner with this program is that, again, we give them access to researchers, to educators, to be mentors, to come in and speak to them. That's one component, but then as I said, it's holistic. If there's an urgent family need, they're connected with resources, whether it's something as simple as a BGE bill that needs to be paid, whether they need food, there are resources to help them do that. We can't say that we'll pay the bill, but there are resources to help them get those things done, because we know that if we have a child in the home and it's dark, they can't do homework. If we have a child in the home and it's dark, they may be worried about staying warm and not so much anything else. So we have to get those things in place, resources in place, so that the students can be successful. So what I've been doing in my 2 whole months in the position is surveying the community. So Cheryl and I compiled a survey where I actually do one-on-one interviews face-to-face. Some I've done over the phone, and I've even done some electronically, trying to see what the community believes their needs are, particularly surrounding early cancer detection and prevention. It's interesting that the first question, what do you perceive to be one of the health issues in your community? And it's not cancer, unfortunately. What I've been seeing, addiction. That's what's been coming back. But we also know, we can't treat the addiction part, but again, we can give resources. And we know that there's a link, because when you're addicted, you're not worried about your health. You're worried about your next fix and just trying to survive. So there is a connection there, but it was interesting. I thought that they would come up with a cancer, and it wasn't. It was addiction. So as we move further through the survey, we detailed the questions. What cancer do you think your community most needs to be educated on, so on and so forth? And we get the typicals: breast, colorectal, prostate. And the group that the community believes needs to be educated most are those 30 and under. And not surprising, we target so much of the preventive, mammogram at the age of 40, colonoscopy at the age of 50, and sometimes we don't get that information down to those 30 and under. That, guess what, there's some things that you need to look for. You may not be eligible to have a preventive screening yet, but there's still some things that you need to do to be aware, and so that when you do get that screening, hopefully it will be negative. So thank you for your time. I'll be sitting here. Any questions that you may have? I'm 2 months in. Hopefully when I come back, I'll have a lot more information for you guys. But I'm grateful to partner with Cheryl, and just look forward to doing great work. Thank you so much.
Good morning, everybody, and thank you for inviting me to speak this morning. What I'm going to present is a little bit different from what has been presented so far. This is more of a work in progress. It's the cancer survivorship cohort that we are trying to develop at the University of Maryland. This is a joint effort between Cheryl and others here at College Park, particularly Cher Dalal, who's been working very closely with me. But we also have many other people involved in this effort, and I just want to give everybody credit. So the objective of the Maryland Survivorship Cohort is to identify tumor, patient, treatment, and community-level determinants of disparities in cancer outcomes. And this includes both quality of life outcomes, by which I mean individuals' perceptions of their physical and mental health, and correlates such as functional status, as well as social support, as well as clinical outcomes, being cancer recurrence and death, or second primaries. So health disparities is defined by the Centers for Disease Control as differences in the incidence, prevalence, mortality, and burden of a disease that differentially impacts specific population groups. And some examples of the groups that are affected are different racial ethnic groups, different groups identified by sex or age, as well as socioeconomic and geographic groups. So this slide is an adaptation of a diagram from a publication by Dr. Gorin showing the multi-level determinants of cancer risk and outcomes. And as you can see, you look at the very, oops, going the wrong way. Sorry, I hit the wrong button here. I thought I was getting a, is that the pointer? No. Oh. As you can see, the very proximal, the tumor per se, tumor histology, stage and grade differs by different groups. There are different racial ethnic different racial ethnic distributions. At the individual level, there are differences by age and gender, as well as lifestyle, knowledge, attitudes, and beliefs, and as well as genetics. I'm not going to go over all of them, but if you go up to the highest level, at the national and state level, public policy has a major influence on determinants of cancer risk and outcomes. We don't think of it all the time, but different professional standards, certainly Medicare and Medicaid policies, have a major impact. So for an example, these are statistics on Maryland breast cancer incidence and mortality by race. And as you can see on this slide, incidence is about equal in blacks and whites. However, blacks are about 40% more likely to die from breast cancer than whites. And the reason for this disparity is not fully understood, but it's likely the combined effect of multi-level factors that differ by race. So factors like socioeconomic status, lifestyle, access to screening and treatment, as well as different characteristics of the tumors, as I mentioned earlier. And there are numerous disparities in cancer mortality. And here I'm just showing overall mortality by race and sex. And these are also for Maryland. And as you can see, males generally have higher cancer mortality rates than females. And with the exception of lung cancer, blacks tend to have higher mortality rates from cancer than whites. There's also considerable geographic disparities in cancer mortality. And again, this is a map of Maryland, and the counties with the lowest cancer mortalities are shown in blue, and it goes up to where the highest cancer mortalities are shown in red. And as you can see, Baltimore City, as well as several counties on the Eastern Shore, have particularly high rates of cancer mortality. And these are all age adjusted, so this is not got anything, this is not related to age differences. So in addition to mortality and other clinical outcomes, quality of life is an important consideration when thinking about cancer survivorship. Cancer patients are living longer than they have ever before, and their quality of life is really becoming more and more relevant. So there are numerous disparities in quality of life of cancer patients, and I could not list them all. I just put a couple examples on the slide. Blacks report poorer mental health, measured by factors such as emotional and social well-being, than whites following lung cancer. And younger age, lower socioeconomic status, and rural residents also predict poorer quality of life among colorectal cancer patients. This, however, is an understudied area. And one of the reasons for this is that prospective cohorts of survivors are needed to robustly identify determinants of quality of life and evaluate interventions aimed at improving patients' well-being. So solving this problem of cancer disparity is going to take a multi-pronged approach. It's going to have to take into account community healthcare system, as well as individual and tumor differences. And one of the issues here is most grants are awarded for 3 to 5 years. And this typically is not long enough to identify and follow sufficient numbers of patients for survival outcomes. So resources are needed to support investigator-initiated research to take advantage of the many technological advances in the last couple decades. And included among these resources are biospecimens such as plasma and DNA, and as well as data on characteristics of the community, individual, treatment, and quality of life and survival. So as I noted earlier, the objective of the Maryland Cancer Survivorship Cohort is to identify tumor, patient, treatment, and community-level determinants of disparities in cancer outcomes, including quality of life and clinical outcomes. And the approach is to provide the infrastructure to support University of Maryland investigator-initiated translational research, and that includes the University of Maryland College Park, as well as Baltimore, as well as Bowie State or any place within the university system that is responsive to NCI's Precision Medicine Initiative, as well as behavioral research aimed at improving cancer patients' quality of life. So through the proposed survivorship cohort, we plan to identify and recruit University of Maryland Greenebaum Cancer Center patients, as well as a sample of non-cancer controls, collect blood specimens, as well as demographic, lifestyle, and psychosocial data, and link these resources in a searchable database to tumor specimens and to pathology and treatment data abstracted from medical records using electronic data capture. And finally, we'll ascertain outcomes through actively following patients to ascertain clinical and quality of life outcomes, both clinical and quality of life outcomes. So when we're up and running, this won't be immediate, but when we're up and running, we're hoping to be able to recruit approximately 1,000 cancer patients and 250 non-cancer controls per year. And to be eligible to be a participant in the cohort, this is sort of an issue that is still being discussed among our group, but to be adult, Maryland resident, and have no prior history of cancer except for non-melanoma skin cancer. For cancer patients, it would have to be an incident primary cancer diagnosis and not yet initiated cancer treatment. For controls, we are planning on using visitors to the hospital, including family and friends. This is a sort of a practical choice. It's just we don't have the resources to go out into the community and start recruiting through more population-level controls. But we do plan to frequency match the controls to patients on age, race, sex, and county of residence. And this is just a schemata of the proposed cancer survivorship cohort. And don't try to take it all in. I'm going to go over the different components in a little bit more detail as we go further. But patients will be identified through at the time of registration. And after obtaining informed consent, we'll get blood samples as well as questionnaire data. For patients who have surgery, we'll get samples of the tissue, as well as the copy of the pathology report. We will obtain information on patient treatment, and then we will follow them for quality of life and clinical outcomes, as well as to update some of the exposure data on psychosocial as well as behavioral characteristics. So this is just a summary of the data collection. At baseline, which would be before any treatment, as I mentioned, they'll complete questionnaires, get biological samples. We'll abstract them, start with the abstract of the medical record, and any tissue will be inventoried through pathology. The first follow-up visit, we plan on having a clinic visit. This will be at the same time as they come back for one of their early follow-up visits after they've completed treatment. And again, we will collect questionnaires and biological samples and medical record abstracts. And then subsequently, follow-ups we plan to do by telephone. And so those will be primarily questionnaire data, but also if there's a self-report of a recurrence or a second cancer, we will abstract the medical record to validate that. And for people who are lost to follow-up, we will link to state cancer registries as well as the NDI. Questionnaires, we've been asking people what they think we need to, what kind of information we need to ascertain, and we've gotten a lot of input on a lot of different domains and different questionnaires, and actually for each of these there are multiple questionnaires that you could choose from. So these are still under discussion. What we're planning to do is have a core questionnaire that everybody completes, and this is going to be data, something like smoking, and some core information, and then we can have specialty questionnaires for if people have particular interest with possibly breast cancers. Maybe breast cancer patients, we will want to get more data on hormones than we might for lung cancer patients, let's say. So we're working through some of this now, and we want our questionnaire, our baseline questionnaire, to be about 45 minutes. So this is way too long, and so we're going to have to do some serious cutting. But at least we've got the ideas down. For biospecimens, like I said, we'll be collecting blood, plasma, and DNA, possibly RNA. It's a little bit more difficult to deal with because of storage issues. But the samples will be stored in the pathology biorepository shared service of the Cancer Center, and they'll be stored at -80. For tissues, we will get tumor tissue as well as adjacent normal tissue for patients who have surgery. And this will be in blocks as well as formalin-fixed slides, and some of it will be snap frozen. Also, it will be stored in pathology biorepository. And from the pathology report, we will be able to get information on histology, certain markers like the proliferation marker, Ki67, as well as tumor-specific markers, such for breast, estrogen receptor status. Treatment, that just lists the types of treatment that they might get, and we will be obtaining the treatment data using electronic data capture that is already being developed at Baltimore through the Research Harbor project that Kate Tracy is working on. For patients who are treated, get all their treatment at the Greenebaum Cancer Center, we'll be able to get more details about the treatment, such as the dose in particular of their treatment received. And as I said earlier, follow-up will be by an annual phone call, and for lost to follow-up patients, we will be using cancer registries, obviously the Maryland Cancer Registry, as well as cancer registries in the states where Maryland residents most likely will migrate to. And we'll also use the National Death Index. So just to give you an idea of types of research supported, this is not meant to be total, all-encompassing, just some ideas of what people might want to look at. With the survivorship cohort, somebody might want to identify determinants of clinical response to treatment and differences by race, sex, and age. And here you might be looking at the tumor, what kind of somatic mutations, what's the gene expression profile, or you might be wanting to look at the individual. What's their lifestyle? What are their, what is their genetics? Another area that people might want to conduct research on is characterizing influences on cancer patients' emotional and social well-being, as well as differences by race, sex, and age. And here we're thinking of psychosocial, lifestyle, healthcare system, as well as community differences. And our long-term goal is to translate our basic findings into clinical practice, as well as cancer control interventions. So our future directions, initially we plan to develop the survivorship cohort through the Greenebaum Cancer Center, but as we get established there, we plan to extend to the Cancer Center's network hospitals. There are Cancer Center network hospitals in Towson, which is the suburbs of Baltimore City. There's another one up in Chesapeake, I think, as well as there's another one down this way. So the idea behind the network is to increase the number of and diversity of participants, as well as increase the generalizability of our findings. We aim to be submitting investigator-initiated grants within the next 3 years. We don't need the whole cohort established to start doing that. And once we are established, we intend to apply for NCI cohort infrastructure support. And they require to get infrastructure support a quite large cohort of 5,000 patients. But that is our aim. And I think, and this is like I said earlier, many people are involved in this effort, and this is our steering committee showing the different disciplines involved: epidemiology, clinical oncology, surgical oncology, psycho-oncology, and going on and on and on, behavioral sciences, family and community medicine, nursing is important also, statistics and data management, as well as 2 patient advocates. And so we have identified one so far. So that's it. And if you have any questions, that's great. We're happy to answer any questions about any of the presentations. Also, we're going to be around this afternoon, and please feel free to approach us if you have any ideas. We have a table. One of the tables is for the Cancer Center and our program. And if you have any suggestions about the cohort, we're more than happy to hear them. We want to make this a resource that can be used very broadly across both campuses. And so if somebody has some ideas of things that they think should be included, we're more than happy to hear those. Thank you.
To take questions. This is a time for comments and questions and suggestions.
Hi, you talked about collecting community-level information. I was curious if you're collecting any information about environmental exposure, and if so, how you plan to identify that.
So, whether there's any...
Hello? Can you hear me? What we're planning on doing is we'll have addresses for everybody. And so if somebody is interested in community or environmental exposures particularly, there'll be the ability to geocode and take advantage of all of the geocoding resources that are available.
I'd like to ask a question about the partnerships that you are probably forming with county and city, as well as the state health department, given the roles that they play in cancer prevention and management and statistics. Is there plans to incorporate them onto your outreach team?
Are you talking about the survivorship cohort or more broadly in the program?
Well, in both, actually. Both the survivorship as well as the overall program.
For the survivorship, yes, we do plan to include people from the state level. I see Dave sitting right over there from the cancer registry, so yes, we do plan on working with them. I'm on a couple of committees with the state at this point, looking at cancer in the state, and so we'll be able to bring some of that expertise on board. For the program, actually, many state employees are on our mailing list. They asked at one point, Cheryl and I gave a presentation about a year ago, I think, to people from the state, and they wanted to be included in our mailing list. So they get our mailing list, and they know everything we're doing, because that's how we communicate with all our members. So they're aware of that.
Well, thank you very much. One more question, Adele, and then we will close.
I'm Associate Dean for Research in College of Ag and Natural Resources. And I have a PhD student who has been working on relating for example, cancer, to different types of cancer, to groundwater quality or environmental type factors. And I had a previous PhD that finished actually childhood cancer, and thanks for Maryland Cancer Registry that we got data. My question is related to almost like along the lines of what Dr. Kleinman mentioned. So you have access to the data with Maryland Cancer Registry, I am assuming, and plus the health departments in each of the counties or whatever counties we have. We have a, for example, in Frederick County, the health department, they have a huge technical advisory committee, and my grad student and I have been attending that. There are community people, there's a medical doctor from the health department, and in fact, Maryland Department of Environment representative and Cancer Registry have been there. So do you all access those and to put the data into a common repository type thing into future that everybody can have access to it scientifically?
It's that's something that we have not really thought about yet. We're kind of a new program. We've only been in existence for a couple years so far. But it's certainly an excellent idea, and maybe we can talk about your ideas a little bit more after this presentation.
Cheryl, did you want to add?
You know, and I think that relates to there are these sources of data, and I think that's relevant for the survivorship initiative, and something that we do need to take a look at. But also the relating to the connection to the health department. I know it's been probably very too long. I've sat down with Pamela Creekmore a while back and too long ago, and I know we need to circle back on that to explore how we can interface with the health department. But I think that these are logical connections that need to be visited and revisited to see how we can work together more closely. I know our community partner, one of our community partners, Community Ministry of Prince George's County, does serve as a very nice conduit to make those connections. But honestly, for me, that's been a little bit of a blind spot. I need to get a little more acquainted with the health department and those connections, and would be very, very interested in doing so.
Well, join me in thanking Drs. Holt and Dorgan and our community health educator and Dr. Cheryl Holt for their presentation and our sneak peek into this future initiative. And I know that everyone here is going to do their part to help and be supportive. So